Hello everyone, my name is Samuel and I'll be taking you to cholinergic pharmacology. Alright, so let's start. This will be our outline for the entire presentation. Okay, so just a brief overview of the nervous system. The nervous system is divided into two parts. We have the peripheral nervous system and then the central nervous system. Okay, the central nervous system is divided into the brain and then the spinal cord. These are the main parts that makes up the central nervous system. The peripheral nervous system, however, has two main branches. Functionally, we have what we call autonomic and then the somatic nervous system, but these are supplied by nerves. And so the nerves that supply them are afferent nerves and then the efferent nerves. The afferent nerves are the one that transfer sensory information to the central nervous system, and after processing is done, the input or the output is sent to the efferent nerves, and those are the ones that are sent to the autonomic and then the somatic nervous system for other final processes. The autonomic nervous system is under involuntary control, so reflex action, and is divided into two. We have the parasympathetic nervous system, which is also known as the cholinergic, and then the sympathetic, which is the adrenergic. In this case, we will be focusing more on the cholinergic. We also have the one that is under voluntary control of the brain, which is the somatic nervous system. Okay, so like I mentioned, when you take the nervous system, it has two main functional groups. We have the somatic portion and then the autonomic, which is the visceral portion. The autonomic portion innervates these ones, the glands, the smooth muscles, and then the cardiac muscles. All right. They also mentioned that we have the afferent and then the efferent. Afferent transfer sensory info to the CNS, and then the efferent transfer from the CNS. Now, the main focus for this presentation is the parasympathetic nervous system. But then we have to be able to differentiate between the parasympathetic and the sympathetic. The sympathetic nervous system is the one that comes into play when your body is active. And so we say it is the fight or flight response. And it's mainly found from the thoracic portion of the spinal cord to the lumbar portion, specifically T1 to L2. Okay, and they have short preganglionic axons and long postganglionic axons. What does it mean? When you take the sympathetic nervous system, a ganglion is simply a group of nerves outside the central nervous system. Okay, so when you have a collection of nerves, it forms a ganglion. The preganglionic nerve is the one that supplies the ganglion first, and then the postganglionic would receive from the ganglion. If the sympathetic nervous system has a short axonal preganglionic nerve or neuron, and then the postganglionic axon is very long. Okay, compared to that, the parasympathetic nervous system, which is the rest and the digest system, arise from the brainstem and then S2 to S4. The brainstem means that we get some portions from the cranial nerves 3, 7, 9, 10, and then the pelvic splanchnic nerve, that is from S2 to S4. It has a long preganglionic axon and then a short postganglionic axon compared to the sympathetic nervous system. We also have the enteric nervous system. The GI tract is also like a whole nervous system on its own, and the enteric is the one that would innervate the gastrointestinal smooth muscles and glands. Okay, now back to this diagram. As I was saying, when you take the parasympathetic nervous system, all neurons transmit the information in the form of action potentials, and when it gets to the axonal terminal, what happens is that there is the release of neurotransmitters, and these neurotransmitters are the ones that will send the information to the other neurons or to the effector cells. And so between neurons, that's the preganglionic neuron and the postganglionic neuron, what is released is acetylcholine. And for the parasympathetic nervous system, the postganglionic neuron will release the same acetylcholine. Okay, unlike the sympathetic nervous system, preganglionic, postganglionic, same acetylcholine, but then postganglionic neuron will release norepinephrine and then sometimes epinephrine. The adrenal glands is kind of like an exception in the sense that it's only supplied by a preganglionic neuron, and this releases acetylcholine, which binds to the receptors on the adrenal medulla to release epinephrine and norepinephrine. So this, in essence, is going to enhance sympathetic response. Okay. Now another thing is that when you take your somatic nervous system, the neurons are just supply the skeletal muscle straight, so they release acetylcholine, which binds to the skeletal muscles. There are nicotinic receptors, and that would tend to trigger contraction or relaxation. Okay, with an exception of sweat glands. The sweat glands are sympathetic. They are part of the sympathetic nervous system, but then they are innervated by parasympathetic nerves. Okay, so it makes use of acetylcholine instead of um, norepinephrine and then noradrenaline. Okay, now I mentioned neurotransmitters. Neurotransmitter at all synapses is acetylcholine and is released by both the preganglionic and then the postganglionic neurons. And then I also mentioned that the receptors that could be found at the effector cells, we have muscarinic receptors and then we have nicotinic receptors. Nicotinic receptors are in two. We have those that are found in the autonomic ganglia and those that are found in the skeletal muscles, like I showed from the somatic nervous system. Those are NM receptors, and then these ones are NN receptors. The muscarinic receptors are grouped into 5 subtypes. We have M1 to M5, and then they are metabotropic in the sense that they are G protein coupled receptors, so they require secondary messengers to transmit the information. And so we have various subtypes M1, M2, M1, M3, and M5, which uses the GQ G protein receptor, and that activates the IP3 and then DAG system, which tend to elevate the calcium levels. Okay, then M2 and M4 use GI. I means inhibitory, so it tends to decrease the levels of cyclic AMP. We have GS, which tends to increase the levels of cyclic AMP. Alright, once cyclic AMP levels are decreased, there's decreased cellular activity. The muscarinic receptors are distributed across the body. And so when you see M1, almost all the receptors are found in the nervous system, but then the M4 and M5 are the most important or the prominent ones found in the central nervous system. Okay, the M1 receptors are located in the sympathetic postganglionic neurons. M2 receptors are found in cardiac muscle and then the smooth muscles. And then M3 receptors are the ones that are very, very numerous, and they are found in the glandular cells and then vascular endothelium and vascular smooth muscles. Okay. Like I said, the M4 receptors are found in the central nervous system, M5 in the central nervous system, and then the vascular endothelium too as well. Now, what is the function of the parasympathetic nervous system? Since it's the rest and digest system, it helps us to constrict our pupils, and the constriction of the pupils is meiosis. And then we also utilize the parasympathetic nervous system in accommodation of the eye. The heart rate decreases with respect to the parasympathetic nervous system, and that is a negative chronotropy. And then it also decreases the conduction process of the heart. The lungs also narrow. The airways become very narrow. That's termed as bronchoconstriction, and there is increased mucus secretions when the parasympathetic nervous system is in play. And then we have the gastrointestinal system. The contraction of the muscles or the smooth muscles that line the gastrointestinal system is enhanced, and so there is increased peristalsis there is increased GI secretion because the glands are there, and then the sphincter, which is the esophageal sphincter, would relax to enable food to pass through down the GI tract. When you talk about the bladder has a muscle and a sphincter. The muscles contract to pull urine from the bladder, and the sphincter relax open so that the urine can pass through and come outside. In the parasympathetic nervous system, that is what we see. There is the trousseau muscle contraction, and the sphincter will relax to cause urination. Like I mentioned, for the parasympathetic nervous system, once acetylcholine binds receptors on these glands, it tends to increase the saliva, the tears, and then the sweat, or let me say the secretions from the glands. Okay. Now let's look at the synthesis of acetylcholine. Acetylcholine synthesis occurs in the cytoplasm, and what happens is that during the process, choline, which is found in the extracellular space, will move from the extracellular space into the cytoplasm. And in the cytoplasm, it combines with acetylcholine with the help of an enzyme called choline acetyltransferase into acetylcholine. Okay, this acetylcholine is then stored in vesicles by the help of a vesicular acetylcholine transporter, and when we have enough, or when the body needs it, it is then released to the outside. Now the release of the acetylcholine to the outside is triggered by calcium levels. When there is increased calcium levels, then the vesicle will tend to fuse with the membrane of the neuron, or the postsynaptic receptors, the presynaptic neuron. So it fuses with the membrane, and then eventually it is released outside. There is the help of these nerve proteins which also help in the release of the acetylcholine. Okay, once acetylcholine gets to the synapse, the synapse could be between an effector cell and then the neuron, or between two neurons. That's a preganglionic neuron and a postganglionic neuron. These acetylcholine will bind to receptors, or it can be metabolized or degraded by an enzyme called acetylcholinesterase into choline and an acetate, where the choline will go back into the cytoplasm to form another acetylcholine. Okay. Now, once acetylcholine binds to these receptors, it tends to trigger the actions that we described in the earlier presentation. Acetylcholine is not administered parenterally or IV for therapeutic purposes. Why? Because it is hydrolyzed by specific enzymes called beta-cholinesterase. It is the same as the acetylcholinesterase, just that this beta-cholinesterase is found in the plasma. Okay, so once we give it into the blood, it just immediately is broken down. Okay, so let's move on. The effect of acetylcholine can be enhanced. So sometimes we want to stop the effect. So we may give agents like hemicolinium, which would prevent choline from entering the cell, or from it will prevent the action of choline acetyltransferase, and so we will not form the acetylcholine. What if we form the acetylcholine, and then but then we want to put it into a vesicle? We can stop the acetylcholine from entering the vesicle by using vesamicol. What vesamicol does is that it's going to displace the acetylcholine in the vesicle, and so there will be no room for acetylcholine to enter. Okay, we can also have some agents that would tend to block the fusion. Okay, we can utilize some calcium channel blockers so that calcium will not come. Or remember I said that these nerve proteins helps in the fusion of the vesicle with the membrane. And so we have agents like botulinum toxin that would block the action of these nerve proteins. All right. Then we can also have other agents that would tend to inhibit this acetylcholinesterase enzyme. Now, once we are inhibiting the acetylcholinesterase enzyme, what we are doing is that we are essentially causing a lot of acetylcholine buildup in the synapse. And when that happens, it means that acetylcholine is going to be, there will be more than enough to bind to the receptors to trigger a lot of actions. Okay, so that is also possible. So we look at enzyme agents that would block this enzyme, and then we will look at some other agents too. All right. So we have agents that directly um, mimic the action of acetylcholine, and those are known as direct parasympathomimetics, and they are cholinergic agonists. Okay. These drugs are subdivided into two. We have cholinesters and then we have alkaloids. Cholinesters include acetylcholine itself. We have methacholine, carbachol, and then betanicol. They are hydrophilic, and so um, they have poor CNS penetration. Hydrophilic means that they are water loving, so they cannot penetrate the blood-brain barrier. Um, with resistance to acetylcholinesterase, it varies between these groups. When you take carbachol and betanicol, they have amide in their chemistry structure, and so these tend to enhance their resistance to acetylcholinesterase. So carbachol and betanicol are resistant to hydrolysis by acetylcholinesterase, and that tends to prolong the duration of action of these agents. But if you take something like acetylcholine and methacholine, they are hydrolyzed by the acetylcholinesterase. All right, because esters tend to increase the susceptibility for acetylcholinesterase to hydrolyze the agent. Then we have the alkaloids. The alkaloids include pilocarpine, muscarine, which binds to the muscarinic receptors. We have nicotine, which binds to the nicotinic receptors, and even lobeline, which also binds to the nicotinic receptors. Most of them are lipophilic, especially with pilocarpine, so it's able to penetrate the blood-brain barrier. And one thing you should take note about the alkaloids is that they are not broken down by acetylcholinesterase. Okay, and there are some structural modifications which tend to increase the selectivity and then the resistance by acetylcholinesterase. If you take methacholine, between methacholine and acetylcholine, methacholine is slowly hydrolyzed by acetylcholinesterase because of the addition of the beta-methyl groups to the structure. Okay, but then the carbomal groups or the amide groups in the botanical and carbachol tend to increase the resistance, like I mentioned. So there are these agents that I want to talk about too. They don't form part of the direct sympathomimetics that are of therapeutic importance. That's how I can put those ones in gray. We have alpha ketoacids and naptoquinones. They tend to directly inhibit the action of what's choline acetyltransferase. Hemicolinium, like I mentioned, tend to block the uptake of choline into the cytoplasm. And then we have vesamicol, which blocks the specific transport process of acetylcholine into the vesicles, so it tends to displace acetylcholine in the vesicles. Like I mentioned, they are poisonous and they are not used for any therapeutic processes. I've mentioned botulinum toxin, we tend to stop the fusion of the acetylcholine in the vesicles with the membrane, and so it's not released outside. And then we have lateral toxin. Lateral toxin tends to produce an explosive release of acetylcholine. And once we have a lot of acetylcholine, remember acetylcholine can bind to the neuromuscular receptors on the skeletal muscles. And so that's going to trigger muscular spasms or contractions, rapid contractions of the muscles. Still on the agents, these are the therapeutic uses of these agents. If you take betanicol, betanicol is used for urinary retention and then paralytic ileus. You may want to take note of paralytic ileus because that is what mostly they bring in the test. Okay, so betanicol for urine retention and then paralytic ileus, and it's selective for GIT and then bladder empty receptors, like I mentioned. If you take something like pilocarpine is used in glaucoma. Why? Because it tends to increase the aqueous humor outflow. Okay, we can also use it in xerostomia to increase salivation. Okay, methacholine is what is used in the diagnosing of asthma, and so what happens is that because it's mimics the action of acetylcholine tend to cause bronchoconstriction. In asthmatic patients, there's bronchoconstriction already, and so that is going to trigger a hypersensitivity reaction from it, and that is used under careful considerations to diagnose asthma. Then we have carbachol, which is used in glaucoma as well. So carbachol and pilocarpine, they are both using um, glaucoma. Then we have cevimeline, which is used in Sjogren's syndrome. All right. So in Sjogren's syndrome, those people tend to have dry mouth or what xerostomia. So you want to give cevimeline to stop this activity. Now, the pharmacological effects are the same as the functions that I mentioned, functions of the parasympathetic nervous system. So, in the eye, we are looking at miosis and accommodation, and then in the heart, there is decreased heart rate, and there is decreased what SA node conduction, so AV conduction, and then there is bronchoconstriction in the lungs, and it tends to increase mucus secretions too as well. In the GIT, we are looking at the motility and then the secretions to affected bladder. I told you that the detrusor muscles will contract while the sphincter relaxes to promote what urination. And in the glands, I said that there is increased secretion from these glands, so there's increased salivation, lacrimation, and then sweating. So if you tend to give these agents a lot, that is going to cause adverse effects. And these adverse effects is that there is diarrhea, urination, miosis, bradycardia, bronchoconstriction, emesis, which is the same as vomiting. There's lacrimation, salivation, sweating. All the things that we mentioned as part of the pharmacological effects can be overdone. And so you want to remember that using dumbbells. Okay. Now, these agents are not used in some conditions like asthma because it's going to cause a lot of bronchospasm. In peptic ulcer, remember that acetylcholine, once it binds to the M3 receptors of the parietal cells, is going to cause increased acid secretion. And so you don't want to give any of these agents that mimic reaction in peptic ulcer patients because it's going to cause the acid levels to shoot up. And then in the heart, if a patient comes and is having bradycardia or AV block, you don't want to give these agents because they are going to decrease the heart rate as well. There's also hyperthyroidism, okay, because it's going to provoke arrhythmias, and then mechanical obstruction of the urinary or GI tract. You don't want to give these agents to. Okay. So most of them, the ones we mentioned, are the ones that act on the muscarinic receptors. We have those ones that act on the nicotinic receptors, and by depolarizing the receptors. So the prototype here is succinylcholine, which is two acetylcholine molecules that come together. All right. So the mechanism is that they are depolarizing neuromuscular blockers. So they tend to act on the skeletal muscles. They act as an acetylcholine analog at the NM receptors, and then when that happens, because the action is inotropic, they tend to force open the voltage gated ion channels, and that will cause what depolarization of the post synaptic receptor, which is the skeletal muscle, and they tend to also prevent repolarization, and that is going to lead to what we call flaccid paralysis. So there are two phases. We have the depolarization phase, where there is muscle fasciculations because of the depolarizing actions, and then eventually the action will stop so that we get what flaccid paralysis. And there's what we call the desensitization phase. So after a prolonged exposure to the acetylcholine, the membrane will tend to repolarize and becomes unresponsive to the agent, and that is how the action of this agent is what reverse, and it's similar to non-depolarizing blockade. The properties of succinylcholine is that it has a rapid onset and a short duration because the plasma cholinesterases would tend to hydrolyze them. You cannot reverse these agents by neostatement, okay, and it's used for rapid sequence intubation, especially in surgery cases. If you want to intubate and you want to give succinylcholine. The side effects is that tend to cause hyperkalemia, especially in people with burn, Okay, there is increased potassium levels. It tends to cause malignant hyperthermia and bradycardia, and also increased intraocular and then gastric pressure. So we don't want these side effects. Other nicotinic agonists that mimics the action of nicotine are nicotine itself, which is mostly found in the CNS and then the autonomic ganglia. And then we have carbachol, as we've already mentioned. Carbachol has both muscarinic and nicotinic activity, as some researches show. Then there are the agents that I mentioned. They block the action of what acetylcholinesterase, and these ones are the indirect parasympathomimetics. And what they do is that they inhibit the action of acetylcholinesterase, and so there is increased levels of what acetylcholine at the synapses, and that is going to enhance both the activity of what the muscarinic and then the nicotinic receptors, and so they are useful in clinical medicine, toxicity, and then what diagnostics. Now we can categorize these ones into short acting, intermediate acting, which is reversible, and long acting, which are irreversible. The short acting one that is known is hydrophonium, which is used in the diagnosis of what myasthenia gravis. And then we have the intermediate or reversible acting ones, which are neostigmine, pyridostigmine, physostigmine, and donepezil. Okay, the long-acting ones are organophosphates. They are the ones that are found in mosquito sprays and other insecticides. So we have malathion and then parathion, and then we have ecothiophate and sarin, which is a net gas. Okay, the mechanism of action, like I explained, is that they inhibit acetylcholinesterase enzyme, and that will lead to accumulation of beta of acetylcholine, and this is going to cause a lot of activities within the muscarinic, nicotinic, and then the CNS. Okay, so let's take the agents one by one. Hydrophonium, like I mentioned, is short acting, and we use it in the testing of myasthenia gravis, and it's called the tensilin test. Okay, is used in diagnosis, not to treat, and it differentiates myasthenia gravis from what cholinergic crisis, and this is also high yield. We want to remember that in the exams. And neostigmine reverses the non-depolarizing muscle relaxants. It's a reversible acetylcholinesterase, and that is the one that is used in the treatment of myasthenia gravis. We can also use in post ileus and then urinary retention. You want to remember this. Neostigmine, neo means no, so there is no blood-brain penetration because it has a positive charge, so there is poor CNS penetration. Then we have pyridostigmine, which is the long-term used as a long-term management of myasthenia gravis. So you want to look at this. Remember pyridostigmine. Pyrite, rate of what myasthenia gravis. So rate GM myasthenia gravis. Okay, so it gets rid of myasthenia gravis. It has a slower onset and then long-acting than what neostigmine. We also have physostigmine. Physostigmine is used in the treatment of anticholinergic toxicity, and it freely enters the CNS because it is what lipid soluble. Okay, it is lipid soluble, and what is used that if we have a drug like atropine, which is a blocker, a sympathomimetic or a cholinergic blocker, it overdose of it is going to cause toxicity, and so we use physostigmine to reverse it. Donepezil, rivastigmine, galantamine, Donriva, forgot the gala, are used in the treatment and the management of Alzheimer's disease. We also mentioned ecothiophate as an organophosphate is used as a long-term management in glaucoma. So if we have organophosphate toxicity like the phentoin, parathion, or malathion toxicity, then what happens is that because these are irreversible agents, they tend to cause aging, which is chemical stabilization of the enzyme over time. Okay. So the signs of cholinergic toxicity, it's because we have a lot of buildup of acetylcholine, because the enzyme is irreversibly inhibited. It will have effect on the muscarinic receptor that's going to cause dumbbells, diarrhea, urination, meiosis, bradycardia, bronchoconstriction, emesis, lacrimation, salivation, and sweating. And in the nicotinic receptors, because most of them are found in the CNS, you would, and then the muscular receptors, we will have fasciculations, cramps, and weaknesses, and sometimes um, paralysis of the skeletal muscles. They tend to cause tachycardia and hypertension too as well, because we can find them in the vascular endothelium and the vascular smooth muscles. We have CNS effects like anxiety, confusion, seizures, and then coma too. So how do we reverse this toxicity? It's a toxin, so we give an antidote. The antidote is that we give atropine, which blocks the muscarinic receptors. But atropine alone is not going to reverse the paralysis. So what we do is that you tend to give atropine together with what we call pralidoxin. Okay, pralidoxin tend to reactivate that acetylcholinesterase before aging, like we mentioned, the chemical stabilization happens. Okay, the contraindication is that you don't want to use asthma, bradycardia, GI obstruction that I can mention. Why? Because excessive dosing is going to cause cholinergic crisis, and that is going to lead to what? Flaccid paralysis. Okay, now let's look at the blockers or the cholinergic antagonists. These are also called anticholinergics, and these inhibit the parasympathetic activity by blocking acetylcholine receptors, and that is going to lead to what? The activity being reversed, what we call sympathetic activity. Okay, so one thing you want to take note of is that the cholinergic blockers or the antagonists tend to act like sympathomimetics, or they tend to act like agents that cause what? The enhanced effect of sympathetic nervous system. Okay, so they have two main activities in muscarinic and the nicotinic receptors. Muscarinic antagonists tend to block the muscarinic receptors, and that those ones do not affect the nicotinic receptors. Okay, but the nicotinic antagonists also will block that of the autonomic ganglia and then the ones at the neuromuscular junctions. The agents are atropine, scopolamine, ipratropium, or tiotropium. Atropine, like we mentioned, is used for the management of bradycardia and organophosphate poisoning, and sometimes in pre-anesthesia. Scopolamine crosses the blood-brain barrier, and so we use it as an agent for the treatment of motion sickness. Okay, we have ipratropium and tiotropium. They are bronchodilators. They tend to bronchodilate or open up the airways. So we use them in the management of asthma and then COPD. Benztropine and trihexyphenidyl, they are used in the management of Parkinson's disease. So if you want to remember this, pack my Benz for benztropine, pack my Benz, benztropine, Parkinson's. Okay. Then we have the agents that tend to affect the bladder. When the bladder is overactive, we use these agents which make the bladder soft. So sulfasenacin, oxybutynin, flavozate, and then tortirodin. Okay. Then we also have glycopyrrolate, which reduces the secretions of organs preoperatively, and then we use it in the management of peptic ulcer. Therapeutically, this is not used. Okay. Now the antagonists are also grouped into two. We have tertiary amines and then quaternary amines. The tertiary amines are atropine, tropicamide, somatropine, cyclopentolate, pyrazipine, benztropine, the agents that we mentioned, and then the ones that are quaternary are ipratropium, propantheline, and atropine metonitrate. These ones are quaternary, and so they do not readily cross the blood-brain barrier, and so they tend to cause little to no CNS effects. Okay, but they do produce more peripheral effects with reduced CNS effects. The tertiary amines are well absorbed from the GIT, and they cross the conjunctival membrane, and they can also cross the blood-brain barrier. So anything tertiary is able to cross the blood-brain barrier. Quaternaries do not cross the blood-brain barrier. You want to remember this for the exams. Okay, still on the antagonist, the main agent we are talking about is atropine. Now, atropine tends to block the activity of acetylcholinesterase, and so that is going to enhance more sympathetic responses. And so low dose atropine will cause decreased salivation and sweating, and it will tend to increase the heart rate, so tachycardia, they decrease GI motility and then urination. And then very high doses will tend to excite the central nervous system, and that's going to cause restlessness and sometimes hallucinations. So the side effects are remembered using these mnemonics. So hot as hell, which is hyperthermia, dry as bone, so dry mouth, dry skin, red as beet, which is flashing, blind as bat. There's mydriasis. Remember we said that parasympathetic nervous system tend to cause meiosis, where the pupils would constrict. Now pupillary dilation is termed what? Mydriasis. And then we have cycloplegia, which is when your eyes are unable to what? Accommodate. Remember, sympathetic nervous system tend to, the parasympathetic nervous system rather tends to what? Cause accommodation effects of the eye. And so when you block that, you get cycloplegia. And then we have mad as hatter, that's delirium agitation. That's when you have CNS excitation. Full as flash, that's going to cause urinary retention, because in this sense the detrusor muscles are not contracting and the sphincter muscles are contracting. Do you understand? And so that will tend to build you get to build up of urine in the bladder. The contraindications to the use of atropine is glaucoma, because they have especially in the narrow angle glaucoma. Okay, you don't want to use atropine. Benign prostatic hyperplasia, due to urinary retention risk, you don't want to give atropine. In an elderly patient with dementia, don't give atropine because it's going to worsen their cognition. Then we have selective nicotinic antagonists, and those ones are categorized into ganglion blockers and then neuromuscular blockers. The ganglion blockers are hexametonium and mecamelamine, and these ones are the ones that tend to block the transmission at both synaptic and then parasympathetic ganglia, sympathetic and parasympathetic ganglia. Okay, the neuromuscular blockers are the ones that whose effects are seen in the skeletal muscles, and so these ones tend to act they act like the succinylcholine that we mentioned as the agonist. So we have tubocurarine, pancuronium, rocuronium, vecuronium. These ones are neuromuscular blockers, and their use is well enhanced in the anesthesia by the anesthesia people. Okay, once we have these are competitive antagonists to the acetylcholine, so they block the receptors. Okay, they are reversed by acetylcholinesterase inhibitors like neostigmine, and we said that we have the depolarizing agent, which is succinylcholine. Succinylcholine's initial action is like it as an agonist, then later on it becomes an antagonist. Okay, so it causes rapid short-term muscular paralysis. Remember, we called it what? Flaccid paralysis, and that's used for intubation, like you mentioned. So this is just a summary of what we've discussed so far. The common causes of organophosphates are the insecticides, organophosphate poisoning. We have the insecticides, so parathion and malathion, and you want to reverse that by what? Giving agents like atropine and then pralidoxime, okay, together. Mushrooms contain muscarine, and muscarine tend to act as an agonist to the muscarinic receptors, and that is also going to enhance the activity. And so we want to reverse the the toxicity of muscarine, and so you give atropine to reverse that. Overdose of anticholinesterases, you want like neostigmine and then phytostigmine to you give atropine. Nerve gases are also like that. So in summary, we said that when you have enhanced muscarinic effect, you remember that with what dumbbells, that's diarrhea, urination, meiosis, bronchoconstriction, bradycardia, emesis, lacrimation, salivation, and what sweating. They also tend to have nicotinic effects, which is muscle fasciculations, cramps, paralysis, hypertension, and then tachycardia. Okay. CNS effects are confusions, convulsions, coma, respiratory depressions. All right. Benzodiazepines are ones that are used in the control of what seizures if any seizure is what's present. So this is a mind map to help you remember some of the agents. So cholinergic pharmacology, in summary, we have agonists. The agonist can act in the nicotinic receptor and the muscarinic receptor. Nicotinic receptor, we are looking at succinylcholine acting on NM, and then the direct ones are of the muscarinic. We have acetylcholine, methacholine, carbachol, betanicol for what paralytic ileus, and then what bladder retention. We have pilocarpine used in glaucoma. We have cevimeline, and then the indirect ones are the ones that block acetylcholinesterase. So they need dacrin, rivastigmine, hydrophonium, pyridostigmine, and then the organophosphates are the irreversible ones. Then we talked about the antagonists. Antagonists could be centrally acting and then peripherally acting. The centrally acting ones are the ones that release. We have those that tend to block the action of the fusion of the membranes. That's botulinum toxin, fusion of the vesicles with the membrane. We have vesicular uptake inhibitors like besamicol. Then choline uptake inhibitors are like what emicolinium. And peripheral acting ones, we can have those that have effect on the nicotinic receptors. So NN receptors, we have hexametonium, melamine, tubocurarine, and tubocurarine is found in especially the neuromuscular receptors. Then we have the peripherally acting, those that act on the muscarinic receptors, and the main agent that is used is what? Atropine. And remember we said that these agents are also divided into two. We have the tertiary and then the quaternary. Tertiary ones do not cross the blood-brain barrier, but tertiary ones cross the blood-brain barrier, but the quaternaries do not cross the blood-brain barrier. Okay, so atropine, omotropine, tropicamide, cyclopentolate. Okay, then scopolamine is used in motion sickness. Benztropine in Parkinson's disease. All right, oxybutynin is used in what the management of what bladder retention. It makes the bladder what soft. All right, so thank you.